is 650.
So we start with inspection. Okay. All right, so we start with inspection of the abdomen. So like we said, the first thing that we need to assess will be the contour. Okay, so what does the abdomen look like? And when we assess for the contour, you cannot look at it from a top view. You need to look at it at eye level. Okay, and the abdomen of Adriana is flat. Okay, like I said, you can have it like rounded, or you may have bigger, a bigger rounded abdomen, protuberant. If it goes that way, then you say it's scaphoid. Okay, so first is flat. Now, we assess for symmetry. Right. To assess for symmetry, it's best to stand at the head of the bed, looking down at the abdomen. Okay, so this is to assess if the umbilicus is at the midline. Okay, so we see that it's at the midline, it's inverted. Okay, and you note the surface motion of the abdomen, the rise and fall. Okay, as a result of respiration. Okay, now, Adriana, you mind lifting up your head? Just the head. Okay, so when the patient lifts the head, it will tense up the muscles. Okay, and this is a means to observe if there are any masses, if there's going to be a deviation of the umbilicus to one side, let's say from a mass. So the what they call this, there were no masses observed. The umbilicus was still at the midline. Okay, and other than some dark lesions, what is? You had a rash? From she. Oh, from she. Okay, so she has some irritation from. All right. So we now part of the inspection will be for if there is a stool sample or for the vomitus we need to describe. So let's start with the stool. Normal stool color.
Brownish, dark.
Dark brown. Okay, and when you say consistency, how would we describe the consistency?
Solid.
Solid.
Semi-formed.
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 Okay.
Solid.
You do not want to say semi-solid or solid, because that would, you would be thinking about food, and then you now relate it to poop, right?
Yeah.
So in the lab we say semi-formed. Okay, it's not supposed to be hard. It's not supposed to be loose. Okay, so semi-formed. Now, let's talk about some abnormalities. If, for example, we have stools that we term as melena, what would be the description of these stools? Okay, so you have dark, tarry stools, melena, and this is a result of
Bleeding.
bleeding where?
GI.
I know, but where?
Upper GI.
Upper GI. So melena, M-E-L-E-N-A. Okay, I'll always be reminded I have a student whose name is Melena. And I go, oh, your parents do not know what the name do. Okay, so that is from upper GI bleed. The reason why it's dark and tarry is because the hemoglobin in the blood has been acted on by the enzymes along the intestinal tract, and so the hemoglobin has been broken down to hematine, which gives that dark color. Okay, now if you have bright red blood in the stool, what is the term that we use?
No, wait, it's coming.
No, that's it.
That's the test.
Hemaemesis.
Mesis.
Hemesis. No, hemopoop.
Hematochezia.
Oh, yeah.
Hemato and then C-H-E-Z-I-A.
What?
Hematochezia. C-H-E-Z-I-A. Chezia. Okay, hematochezia. So that's bright red blood in the stool. What's the most common cause of hematochezia?
Rectal bleeding.
Aspirin.
Aspirin?
Is it hemorrhoids?
Hemorrhoids.
Hemorrhoid.
Okay, the most common cause will be hemorrhoids. Okay. Or you have bleeding from the lower GI. That's why the blood has not been acted upon by the enzymes in the along the intestinal tract. Okay. Now, if we describe the stool as this,
Clay-colored?
okay, gray-colored, as a result of,
Liver.
okay, a problem with the liver. This may be a manifestation associated with jaundice. Okay, because the bilirubin is not metabolized. Okay, so the bilirubin gets deposited in the tissues instead of being eliminated. There is nothing that gives color to the poop. Okay. Now, when we say there is steatorrhea, what do we mean? Oily, fatty stools. So what would be the appearance of fatty or oily stools?
Oily and it.
Okay, yes. So when you look at the poop in the toilet bowl, the poop will be floating and there's going to be a lot of fat globules around it. And it's going to be what they call this yellowish in color. Okay. What about if we say there is occult blood?
Oh, hidden blood in the poo. Yep.
I'm sorry?
Isn't that when there's hidden blood in the poo?
Okay,
like
why is
if
it
you
hidden?
Smear?
Because we can't see.
You can't
The
see it on the
color.
surface.
We can see.
Right.
Yeah, why can't we not see it? We're looking at it.
You can't see it in the surface, so you have to do like a smear?
No, not a smear.
Okay.
Fecal occult test. Okay. Not the reason why it's not seen is because there's minimal amount of blood present, trace amounts as we call it. Okay. So we do an occult test. So you have this packet. Have you not done that? Okay, and then there's two windows. So you take a small part of the poop, put it on smear it on one of the windows,
Yeah.
and then apply a developer. Apply a developer and expect a bluish color. Okay, so this is for what they call this for our occult testing, and it's again, like I said, trace amounts of blood, and commonly it's significant because of colon cancer. Okay, all right. Anything else that we need to add with the poop?
Parasites.
Parasites, yes. So later on, but for the abdomen, we don't assess the anus and the rectum, so you will not be able to see, if there's any signs of parasitic infestation. So just really the abdomen, percussion, palpation, auscultation. Okay. Now, we also need to observe the emesis, if there is any. Okay, so if we have vomitus that contains bright red blood, what do we call it?
Hematoemesis.
Oh, hematemesis.
Yeah.
Hematemesis. Okay, so the patient vomits bright red blood. Okay. What is the difference with hemoptysis? What is the difference with hemoptysis? How can we differentiate hematemesis with hemoptysis?
I don't know.
Hemoptysis is coughing up
Coughing.
of blood, or blood is sputum. So if it's from a cough, then that would be hemoptysis. If it's vomitus, then hematemesis. Now, if for example, we're looking at the vomitus contains this coffee ground material, okay, what would be, so that's also bleeding. Why would it be coffee ground to differentiate it from bright red blood?
Means it's more in the stomach.
Well, both will be from the stomach,
Oh.
but the bleeding would have taken place like a couple of days ago. Okay, like Irena said, older. Older in terms of it's been there for a couple of days, and so again, the blood has been acted on by the enzymes, broken down, hemoglobin is now converted to hematine, so you have that coffee grounds material. Okay, but whether it's the hematemesis or the coffee grounds, it's still upper GI. Upper GI. Okay. All right. So our patient does not have any stool sample. You wanna poop? You wanna? Okay. So no poop, no vomitus. All right. Now we auscultate. So when we auscultate, okay, we need to divide the abdomen into 4 quadrants. Okay, a horizontal, a vertical line along the umbilicus, and then a horizontal line. Okay, so you have the right upper quadrant, left upper, left lower quadrant, right lower quadrant. Okay, so we said that the normal bowel sounds is 30, 5 to 30 per minute. And that's in all 4 quadrants. Okay, so what we can do is to auscultate using bell or the diaphragm. Okay, so we use the diaphragm, listen to each quadrant for about 15 seconds. Now, like I said, if you're not hearing any of the bowel sounds, then you need to assess longer. You can stay in one quadrant for about 5 minutes before you can really say, I don't hear anything. Okay. Let's see. Ready? Did you just eat?
Yeah.
The gurgling is very loud here. There's 12 here. There's 2 there.
Chris always talks in class. It's the coffee.
Okay, so there were like 12 that I heard here. 2, 3, 3. Okay, so you just
17, 20.
so you just add them. In some books, you may even come across the normal vowel sounds extending all the way to 50. Right. But for uniformity's sake, we put it at 5 to 30. All right. So that is for our auscultation. Now, we need to now assess the vascular sounds. This is again for brutes. So to assess for brutes, we need to use our bell. Now, like we said, there will be the arteries that we assess. So over by the epigastric to the left will be the aorta. Right and left lower upper quadrants.
Right iliac.
I'm sorry?
Right iliac.
Renal.
Oh, renal.
So you have right and left renal arteries. And then on the
The iliac.
lower quadrants,
Iliac.
okay, so you have the right and left
Iliac.
iliac arteries. So again, listen for the presence of brutes. No brutes are heard. Now, in addition, we also assess by the umbilical area, and this is for the venous hum. Like I said, this is a low-pitched hum. Okay, and this hum is a result of portal hypertension. Okay, so again, even with the hum, we use our bell. Okay, so the 5 arteries plus the venous hum for vascular sounds. Okay, next, we now go to our percussion. So for percussion, we said that will be our pattern. Okay, so again, okay, can mark the abdomen later. We start here. Adriana, you wanna put- okay, thank you. Do you hear the changes in the tones? Mhm.
Mm-hmm.
Empty. Okay, so you are able to elicit the different tones, the tympanic sounds. You hear where you have the more hollow organs, and the dull tones. You hear where you have the denser organs. Okay, now we do our liver span. So our two landmarks will be the right mid-clavicular line as well as the mid-sternal line. So we start from below the umbilicus, okay, along the right mid-clavicular line until we hear a change in the tone. So percuss until we hear a change in the tone. Okay, so over here, and then you mark it. Okay, now from the area where you have less of the, or where you have the lung resonance, you again percuss. Okay, so that's going to be just below the inferior border of the breast. Let me just start from here. Still along the right mid-clavicular line until you hear a change in the tone. Okay, so here. And then we measure. So we said the measurement here will be about 6 to 12. About 6 to 12 centimeters. Right mid-clavicular line, 6 to 12 centimeters. Okay. Now, let's do the percussion, checking for the liver span along the mid-sternal line. Remember, our liver, it goes this way. It goes that way. It's not a single area there. So we need to assess the liver span near the sternum. So again, from below the umbilicus, percuss until you hear a change in the tone. Okay. And then from below the xiphoid process, percuss going down until you hear a change in the tone. And then we measure again. And along the mid-sternal line, what will be the
4 to 8
measurement?
centimeters.
Okay, so we have 4 to 8 centimeters. Okay. Then we do our splenic dullness. So for the splenic dullness, we said the normal area where you will hear the spleen will be at between the 9th to 11th intercostal space along the left mid-axillary line. So we start from here, okay? Remember, how would you know it's the 9th to 11th? You just need to associate it with the PMI. PMI is the 5th. So move down your fingers. The last ICS will be your 11th. 10, 9. Okay, so just percuss. There will be dullness. Okay. So this area here will be an area of dullness. It's not going to be greater than 7 centimeters. However, if you're hearing the dullness all the way up or all the way down, then that means there is splenomegaly. Okay. Now for the Castle's sign, the Castle sign will be along the 11th ICS, this time anterior axillary line. So along this area. Okay. So, sorry. Okay. So what we need to do Okay, will be to percuss first. You hear the resonance? Okay, now can you please hold your breath? There should not be any change in the tone. The resonance is because of the lung, the lobes of the lower lobe of the lung. So when the patient holds her breath, despite that, there will still be the resonance that you will hear. Okay, relax now. All right. So that is for the Castell's sign, meaning it's negative. There is no enlargement of the spleen. Okay, next, we do our blunt percussion. So for the blunt percussion, just put the hand on under the right costal margin. Okay. Any pain?
No.
Okay. Now can you please sit up, Adriana, for a while? Okay. Now assess. We will assess the kidneys for blunt percussion. This will be if you have here the ribs, that area. Okay. We call this the costovertebral angle. Anything? Anything? Okay, thank you. Down again. Right, so that is for the blunt percussion. And then we have our palpation. Okay, so we said that during palpation, we combine the light and deep palpation. All right, so we follow again this pattern. Okay, so our dominant hand will be the one in contact with the skin. Okay, if we say light, how much of the skin do we depress?
1 centimeter.
Less than 1 centimeter. If it's deep,
1 to 2 inches.
1 to 2 inches. So, small circular motions. Okay. Pain. If there's anything painful. No. Okay. Okay, so the abdomen is soft throughout, no tenderness noted, no masses palpated. Now, if your patient is very ticklish, okay, let's see the guys when they do their assessment on each other. Okay, the guys should just do that and they go, okay, oh yeah, they're more ticklish, you just touch, okay, they start giggling like girls. Okay, so to minimize, the ticklish sensation, what we can do is put the patient's fingers on top of the skin, okay, so that it feels like they're the ones who are actually palpating. Put your fingers in between so you can actually palpate it yourself. Okay.
It's just one side.
There's something wrong. Okay, so this is how we minimize or how to eliminate that ticklish sensation and still be able to palpate your patient's abdomen. Okay, now if, for example, before the palpation, you note that the patient's abdomen is very tense. There is what we call involuntary muscle guarding. This is because there is pain and the patient anticipates that any touch, any, even if it's a light touch on the abdomen, it will elicit pain. And so they're like, holding it, they're guarding it. And so what we can do is to tell our patient, can you please bend your knees? Move. This will relax the abdomen, okay, if the patient has involuntary muscle guarding. Okay. All right, next, we now do our palpation of the liver border. This is part of the bimanual palpation. So this time, okay, put the non-dominant hand, just relax, okay. on the posterior chest wall between the 11th and 12th ribs.